Grab your clavicle. One more time. Is this going to be in your lab exam number 2 next week? No, this is lab number 3, okay?
Yeah.
Okay. So the clavicle, what is the shape of the clavicle?
S.
Not S shape. There's a flat bone, long bone, irregular bone. So it's a flat bone. Okay? Where's your clavicle? So the clavicle, use your book, okay? And I highlighted on PowerPoint what I wanted you to know as far as the different parts are concerned. So you see, look at the clavicle. One is nice and curved. Do you notice that, right? And you see your shoulder is curved. Because one of the things I like to do, to ask, I have an arrow, A and B, and I'll say which of these parts, A or B, is lateral or articulates with the scapula. This is the sternal end, this is the scapular end, right? So just remember your shoulder is curved. And so this one is curved, the other one is not. Whatever will help you remember, that one helps me remember, okay? Another very important thing about the clavicle that you must know, guys, is that the clavicle is actually the only bone that anchors all of this upper appendicular skeleton to the rest of your skeleton. If you look at this one, you notice that the scapula is just only screwed to the ribs, right? So everything else is dangling. The only one that keeps them attached to the center is this small clavicle. And that's why if you have a fracture of the clavicle or injury right here, it's very hard to move. Okay? So next, grab your scapula. So again, look at your A&P book, look at your PowerPoint video, which I highlighted. So one of the things I want to identify or to ask about the scapula, which one is anterior and which one is posteriorly located, right? And if you grab a typical vertebra, where is the spine of the vertebra? Anterior or posterior? The spine. Posterior, right? So you look at this one, it has a spine. That's why this is called spinous process also. The spine of the scapula. Where the spine is, that must be posterior. So if I ask you, it must be like this, right? So then this must be anterior, and where the spine is must be posterior. And it's actually called spine. And remember, I asked you to know the surface markings. A depression is called a fossa. So this is called the subscapular fossa. This is the supraspinous fossa because it's above the spine. This is the infraspinous fossa because it's below the spine. And the muscles there take their names after the fossa. This is the supraspinatus muscle. Down here will be the infraspinatus muscle. Down here will be the subscapularis. So you're gonna know if you know the bony markings, you should be able to know the muscle. Okay. Then you should know which one is the vertebral or the medial side, and which one is the lateral side. This is the vertebral, right? The one that's closer to the center. Then know the acromion, the coracoid process, which is the bird's beak. And then finally, the glenoid fossa, which is for articulation with the humerus. Okay? What's the shape? Flat bone also. Then grab your humerus. So here you have long bones, right? Humerus. You know your humerus? Okay. Okay, so for the humerus, be sure you remember this is a typical long bone, and be sure you remember the parts of a long bone. Remember, The epiphysis, which you have a proximal and a distal epiphysis, you have a diaphysis, then you have the growth plate. So for the humerus, of course, you have the deltoid tuberosity, which is for the tendon of the deltoids, right? Deltoid tuberosity. But there's something very important I want you to remember about the humerus. If you fracture the humerus on 3 sides, right? So if you fracture the proximal 1/3 of the humerus, you have, it's more than likely you will damage the axillary nerve. The proximal 1/3 will damage the axillary nerve, and the axillary nerve supplies the deltoids. So those people, when they have a fracture, they tell them to raise their hand. They can't. They just go like this. They can't, because the nerve that tells the deltoids to contract, to pull it up, is not working anymore. So that's why they can only go up to there, okay? If you fracture the middle 1/3, you may injure the radial nerve. So proximal 1/3 is axillary nerve that supplies the deltoids. The middle 1/3 is the radial nerve that supplies all the extensors of your upper extremity. Look at me. What is this movement?
Flexion,
So what's this one?
extension,
What muscle promoted the extension? Triceps. So what nerve supplies the triceps then? Radial nerve. So all of the extensors, do you agree, are in the, all of these muscles in the back or the posterior compartment, they are all extensors, right? When they contract, they will all extend. So they're all called extensors, the triceps, and then here they're extensor carpi radialis, extensor carpi ulnaris, extensor digit. It's all extensors. And what is the nerve that innervates them all? The radial nerve. There's just one nerve. To remember the nerve that supplies all the muscles here in the posterior compartment, it's called radial nerve. And it passes, it's from the brachial plexus, and it passes through this one to go down to innervate all the extensors, okay? Then the distal 1/3 of the humerus, if it gets fractured, you may run the risk of damaging your ulnar nerve and your median nerve. The ulnar nerve, the funny bone, right? So the ulnar nerve, you see your flexor carpi radial. This is the ulna, right? This is the radius and this is the ulna, right? So the ulnar nerve will supply this one, the last 2 fingers, and the median nerve will supply the rest. So you see, let's say if you fracture the radial nerve, you know that the radial nerve is for extension. You see patients that go like this, right? They can't extend. Varying degrees of flexion, maybe it's like that. They can't extend because the radial nerve is damaged. Maybe it's like that, or that, I don't know, just varying degrees of extension. If it's the median nerve that's damaged, it's supposed to flex this one. So you're flexing this, it stays like that or like that, right? You see them, you can figure out, okay? Then finally, anywhere in there, in the medial third also, you run the risk of damaging the musculocutaneous nerve. Musculocutaneous nerve. Can you write it down, please? The musculocutaneous nerve innervates all of the anterior compartment, everything here. What do you think the muscles here do? They flex. So the musculocutaneous nerve innervates everything here. So what is the muscle to flex your elbow? What is this? So what is the nerve to the biceps? Musculocutaneous.
And what third would that be again?
In all of them.
Oh.
And then what will be the nerve for the flexor carpi? All flexors. As long as it's a flexor muscle, it's all musculocutaneous nerve job. Okay?
And what's the one with the deltoid again?
Axillary nerve. Axillary nerve. There's your axilla, right? That's how I tried it. There's axilla, there's the head of the humerus. Okay? Then also know identify the head of the humerus, the conda, the epicondyles, the trochlea, the olecranon also for the articulation with the ulna, for your elbow joint. Okay? Next we get the radius and the ulna. So you remember the radius has the circle, right? A part of a circle, the radius. And then the ulna has the letter U. That's not the ulna.
Yes.
Okay. So the radius and the ulna. Which one is lateral and which one is medial? This is lateral, right? And this is medial. And you identify the notch. This must be the one that forms the elbow joint, right? So identify the notch. And remember, they articulate with each other. You see this tuberosity right here, and it just fits right there. They articulate together to form the radial ulnar joint. Identify the styloid process of each one. When you write, you have a stylus. And that's what you feel right here, right? This one. And the radial styloid process is a very important marker to feel for the radial artery. Okay? Then I'm gonna proceed to the carpals first. You remember, you look at your work. Oh, okay. Some of you will have a disarticulated skeleton. So you have carpals in a plastic bag. In the test, I will not separate them. I'm gonna make sure that it's like this. Your job is to know their names. So use any mnemonics. What works for me is she looks too pretty, try to catch her. Whatever will work for you. So scaphoid, lunate, triquetrum, pisiform, and then trapezium, trapezoid, capitate, hamate. So, and you just look at it, you say, oh, it makes sense why it's called scaphoid because it forms the scaffolding. And then the pisiform is shaped like a P. That's why it's called pisiform. And the trapezium, trapezoid is shaped like a trapezoid. And they're right next to each other. The scaphoid bone actually is the one that's very commonly injured. When you're trying to prevent or protect yourself from a fall, that scaphoid bone is very commonly broken. And the problem with the scaphoid bone is that is where the radial artery passes through. So the radial artery comes from the carotid, from the aorta, the brachial artery, then it breaks, it separates into radial artery, ulnar artery, and then they join here to form the palmar arch. The radial artery passes through the scaphoid. So when it breaks, when you have a fracture, it can be broken, severed, and you lose the blood supply to the important nerves here. In case you didn't know, right here, you look at this one right here, you got a ton of muscles that help you move this one. So do you remember carpals, then metacarpals, then phalanges? Okay, and then please know that the muscles that will do this one, they're called flexors, right? Flexor. So this is the flexor carpi radialis. You have a tendon. Flexor carpi ulnaris. And then the rest is flexor digitorum. And then over on the opposite side, extensor carpi ulnaris, extensor carpi radialis, extensor digitorum. But then once you open up the cat, you're gonna see that there's a superficial group and a deep group of flexors and extensors. That's why you have so many tendons. To move just a few fingers, there's so many tendons involved like a guitar. And they are all held in place by what we call a retinaculum right there, which I like to ask. I've asked that time and time again in every lab exam. This is the retinaculum. You see the white, like a white rubber band right here, which is not rubber band. It's tough collagen. Okay. It's just like your meninges. You remember you pulled it, it's tough, it doesn't stretch. The job of the retinaculum, over here, this is called flexor retinaculum. And then over here, this is called extensor retinaculum. And the job of the retinaculum is to keep the tendons and nerves and blood vessels in place. You see that? Right? And so when you sleep, you ever sleep like that? You ever heard of carpal tunnel syndrome? right? So what happens is this retinaculum, it doesn't stretch. And so when you go like this, you're compromising the blood supply, and also so when you compromise the blood supply, tissues get there's buildup of waste product in there because they're not able to dump to the circulation their normal waste product. So there's a buildup of waste product here, which then is a signal for the white blood cells to come in. When they see an abnormal collection of toxic chemicals in an area, the white blood cells come. And when the white blood cells come, there's inflammation, and that's carpal tunnel syndrome. And so what they do, they come in there and they just cut to loosen it, okay? And that's why I like you to remember this one. And you look at the anatomy. It limits the movement of all of these structures right there. No wonder carpal tunnel syndrome is very common. So be aware of that. Remember that you always want to go back to the anatomical position as often as you can, okay? And then, what else did I think that's it for today. Then we're gonna continue with the rest of the appendicular skeleton. But on Wednesday, I want you to use all of that time period to review for your lab exam number 2 because we don't have school on Monday, November 11. That means